Case report. A 59-year-old female with a history of Parkinsonism, seizure disorder, and previously operated arachnoid cyst presented with recurrent right-sided abnormal body movements and altered sensorium. Clinical findings suggested focal status epilepticus with possible structural etiology. She was managed with anti-epileptics and supportive care in ICU. This case highlights the complexity of seizure recurrence in patients with prior intracranial surgeries and underlying neurodegenerative disease. Introduction. Focal seizures. In patients with structural brain abnormalities such as arachnoid cysts and post-surgical gliosis, present significant diagnostic and management challenges. Coexisting Parkinsonism further complicates treatment due to drug interactions and neurological overlap. Case presentation: patient information, age/sex, 59-year-old female. Known case of Parkinsonism on medication, seizure disorder, arachnoid cyst, multiple surgical interventions, hypertension, surgical history, arachnoid cyst surgery at tertiary hospital, 10 years back, 3 explorations, repeat surgery at another center, 2 years back, documentation unavailable. Chief complaints: multiple episodes of right-sided abnormal body movements since 7 p.m. one day prior. Altered sensorium, negative history, no vomiting, no head trauma, no clear history of fever. Initially, though later low-grade fever recorded. Clinical findings at emergency: GCS, E2, V3M5S, P02, 88% on room air, HR 130 beats per minute, BP 120 over 70 millimeters of mercury, temp 100.5 degrees Fahrenheit, at ICU, GCS E3 V2 M6, heart rate 78, BP 110 over 70 pupils, bilaterally reactive 2 millimeters, SPO 2, 93% on 5 liters oxygen, R 27 per minute plantar, reflex right upgoing, left downgoing, motor power not accessible, investigations, CBC within normal limits, electrolytes normal, GR, BS 161 milligrams per deciliter. Diagnosis: focal onset seizures with impaired awareness, focal status epilepticus, likely secondary to structural brain pathology, post-arachnoid cyst surgery, changes or recurrence. Therapeutic intervention: injection, levetiracetam, 1.5 grams, BD injection, lacosamide 100 milligrams, BD tab clobazam, 5 milligrams, BD trihexyphenidyl for Parkinsonism, amlodipine supportive care, oxygen therapy, antipyretics, PCM, proton pump inhibitor clinical course. The patient showed mild improvement in GCS after initiation of anti-epileptic therapy and supportive management. However, persistent altered sensorium and focal neurological signs raise concern for underlying structural pathology. Discussion. This case illustrates breakthrough seizures in a patient with prior structural brain lesions, the role of post-surgical gliosis as a seizure focus, diagnostic dilemma between structural recurrence, infection, metabolic causes. The presence of unilateral Babinski signs suggests contralateral cortical involvement. Low-grade fever warrants exclusion of CNS infection. Management requires aggressive seizure control, neuroimaging, CT/MRI, multidisciplinary care. Conclusion: patients with a history of arachnoid cyst surgery remain at risk for recurrent seizures due to structural and gliotic changes. Early recognition and prompt management of focal status epilepticus are crucial to prevent neurological deterioration.